Good afternoon. My name is Janine Vintch. I'm from Harbor UCLA Medical Center in Torrance, and I'd like to thank the California Thoracic Society for allowing me to share with you this afternoon my presentation on anticoagulation in special populations, cancer, renal disease, pregnancy, and obesity. I have the following disclosures. I was a panelist on the 10th edition of the Antithrombotic Therapy for VTE Disease Guidelines, sponsored by the American College of Chest Physicians, and am on currently their new panel updating and revising these existing guidelines. I'm also a member of the University of California Alliance on Pulmonary Embolism. However, the information I'm going to provide for you in today's lecture all comes from peer-reviewed journals and established guidelines on these topics. We're going to review this afternoon the direct oral anticoagulants and discuss current guidelines and published recommendations on the use of these anticoagulants in special populations, including cancer, renal disease, pregnancy, and obesity, with a focus on their use in the management of VTE. We'll do that by going over the DOACs first, then going over each of these populations and the guidelines or recommendations that currently exist, and draw some conclusions at the end. Anticoagulant therapy is complex and associated with substantial benefits and risks. Benefits include the reduced risk of thrombus extension and fatal PE in the acute setting and recurrent venous thromboembolism thereafter, while the risks, as we all know, includes life-threatening bleeding complications. Historically, warfarin was the only oral anticoagulant available and used widely for human use. More than 4 million patients were prescribed warfarin for treatment and prevention of thromboembolic events annually in the U.S. prior to the DOACs getting FDA approved back in 2010. As of 2013, DOACs have surpassed warfarin and are now the #1 anticoagulant written for annually for oral prescriptions for our patients. The direct oral anticoagulants were developed to overcome some of the shortcomings related to warfarin use, including its higher reported rates of bleeding, its need for frequent monitoring, slower onset of action, a narrow therapeutic window, genetic factors that impact on its metabolism, as well as a very long list of both food-drug and drug-drug interactions. These new agents have really changed the landscape of oral anticoagulation use today. The FDA-approved agents that we have available to us include the direct thrombin inhibitor, Dabigatran, which was the first agent FDA-approved back in 2010, followed by a whole host of factor Xa inhibitors, starting with Rivaroxaban in 2011, Apixaban in 2012, Adoxaban in 2015, and more recently, Vitrixaban in 2017. All of them are FDA approved for stroke prevention and non-valvular atrial fibrillation, as well as the treatment and prophylaxis of VTE. More recently, Rivaroxaban also got FDA approval for the prevention of major cardiovascular events in patients with chronic coronary artery disease and peripheral arterial disease. Let's move on to the anticoagulant agents. This is just to remind you about the intrinsic and extrinsic pathways for coagulation, which come down to the common pathway, which is where factor 10 is situated, where the factor Xa inhibitors act, and then thrombin, the next step below that, which is factor 2, which is where the direct thrombin inhibitors actually act to knock out your coagulation cascade. So let's talk about these factors individually. The direct thrombin inhibitors do inhibit the intrinsic activity of thrombin directly, which is factor 2. It does not require a mediating factor and inhibits this factor directly. We have a host of parenteral agents that have been around for quite some time, which range from argatroban, veliparudin, desarudin, and bivalirudin. All of them are alternative options for management of patients with heparin-induced thrombocytopenia. The oral agent, though, that we'll talk about now is Dabigatran. It binds directly and competitively as well as reversibly to the active site on thrombin. It inhibits both the free and clot-bound thrombin while preventing thrombin-induced platelet aggregation. It's not readily absorbed, however, from the GI tract due to its high polarity and is given in a prodrug. Each capsule, if you were to look at it, is composed of these little pellets that are drug-coated on tartaric acid core that creates an acidic microenvironment that favors drug dissolution and preserves your gut's absorption of the medication. It is notable if you give patients a PPI or a proton pump inhibitor along with Dabigatran, it can actually decrease absorption by as much as 40%, and that was seen in patients who were healthy. Therefore, this should be something you should think about when prescribing this drug to patients who are on a PPI. It may impact on your therapeutic levels. Its peak plasma concentration occurs within 1 to 3 hours of ingestion. It does, however, require 5 to 10 days of treatment with parenteral anticoagulation before actually starting the oral drug itself. It's excreted predominantly unchanged by the kidneys, with a half-life of 12 to 17 hours when patients have normal renal function, and extends out to as long as 27 hours when creatinine clearance is less than 30 mils per minute. There are no dosing recommendations for patients with VTE who have creatinine clearances below this range. There are, however, no dose adjustments needed for patients with moderate to severe hepatic disease. There are no interactions with this drug with the cytochrome P450 system. However, it is a substrate for the P-glycoprotein cell efflux transporter, which is responsible for most of its drug-drug interactions. P-glycoprotein inhibitors will lead to increased dabigatran levels, while inducers will lead to reduced dabigatran levels. Common inhibitors you may prescribe are amiodarone, quinidine, verapamil, ketoconazole, and clarithromycin, while the most common inducer that might be actually prescribed is rifampin. Factor Xa inhibitors inhibit the first step of the common pathway and interrupt both the intrinsic and extrinsic pathway. They bind to the active site of factor Xa and inhibit both its free and clot-associated forms. It's administered both orally as well as parenterally. Today we'll talk about the oral agents, Rivaroxaban, Apixaban, Dabigatran, and Vintch. But don't forget that fondaparinux is also a factor Xa inhibitor that's parenterally used and impacts on the system by indirectly inhibiting factor Xa. We'll start with Rivaroxaban, which is a synthetic molecule that selectively and reversibly inhibits factor Xa in its free prethrombinase complex bound as well as clot bound forms. It disrupts interactions with platelets, thrombin, and the prothrombinase complex. Its half-life is the shortest of all the DOACs at 5 to 9 hours, and it's rapidly absorbed and reaches peak plasma levels within 2 to 4 hours. However, it is recommended that it be taken with the largest meal of the day. Its half-life does get a little bit longer in the elderly and can be as long as 11 to 13 hours based on age alone. It does have a dual mode of elimination, with 35% of the drug excreted by the kidney unchanged and 65% undergoing metabolic degradation. It is highly protein-bound and cannot be eliminated during dialysis. We'll review this later, but it is not recommended for patients with creatinine clearances less than 30 mils per minute, and it's also contraindicated in patients with moderate to severe liver disease. Apixaban is a direct factor Xa inhibitor that also reversibly binds to factor Xa, whether it's free or bound to platelets, thrombin, or the prothrombinase complex. Its half-life is a little longer at 10 to 14 hours in patients with normal renal function and reaches peak plasma levels within 1 to 3 hours. About 27% of the drug is excreted by the kidneys, and it is contraindicated in patients with moderate to severe liver disease. It is the only DOAC that demonstrates a lower incidence in the rate of overall major bleeding episodes or events. Data from the initial 6 trials evaluating all the DOACs that are currently in use, comparing them to the vitamin K antagonist or warfarin, demonstrated that Apixaban was associated with significantly fewer major bleeding events, with the pooled data showing a 0.6% rate of bleeding compared to 1.8% for all the other DOACs. Both Rivaroxaban and Apixaban undergo significant metabolism through the liver, involving both the cytochrome P450 system and the intestinal absorption through the P-glycoprotein transporter. These are responsible for potential significant drug-drug interactions. Just like with Dabigatran, strong inhibitors of either one of these systems will cause a reduction in the clearance of the drug and therefore increase drug levels. That includes, again, amiodarone, the azoles, macrolides, verapamil, and also the protease inhibitors. While strong inducers, which is something along the lines of rifampin, will actually decrease the drug concentration levels. The next agent is Edoxaban. It's a selective inhibitor of both free and prothrombinase-bound factor Xa. Its half-life is also 10 to 14 hours, and it reaches peak plasma levels within 1 to 2 hours. It has a dual mode of elimination, with about 50% of it excreted unchanged in the urine and the rest of it excreted through the biliary and intestinal system. It is not metabolized through the cytochrome P450 system, and it is contraindicated in patients with moderate to severe liver disease. It does require, similar to Dabigatran, an initial 5 to 10 days of parenteral anticoagulation prior to starting this agent itself. And of interest, it has decreased efficacy when patients have an elevated or high normal range creatinine clearance of 95 mils per minute, and it's actually listed as a black box warning on its label. Vitroxaban is the newest kid on the block. It was FDA approved only for VTE prophylaxis based on the APEX trial that came out that studied its use in the acutely medically ill patient and DVT prophylaxis alone. It has not been studied in acute VTE or in the prevention of VTE recurrence. Of all the DOACs, it has the longest half-life at 35 to 45 hours. It is mainly cleared via the hepatobiliary system and is not therefore contraindicated in patients with severe renal insufficiency. Let's now start talking about our special populations, and we'll start with cancer. Cancer patients have a 4 to 7-fold increased risk of VTE and a 2-fold increased risk of major hemorrhage on anticoagulation compared to patients who do not have cancer. VTE is reported to occur in 5 to 10% of all cancer patients, and 5 to 10% of these patients will develop their event within the first year of being diagnosed with their malignancy. Cancer patients have a 2 to 9-fold increased risk of having a recurrent VTE event, and many of the patients' VTEs are actually found incidentally on screening CT imaging, both for the diagnosis or surveillance of their cancer therapy. It is associated with significant morbidity and mortality in cancer patients and commonly interferes with their cancer treatment. It's found to be the second most leading cause of death in cancer patients, right behind cancer itself. And whether it's symptomatic or found incidentally, cancer-associated thrombosis is a marker for poor prognosis. Of life expectancy in many of our cancer patients is actually increasing with the use of more patient-centered and tumor-targeted therapy. Safe and effective strategies to ameliorate this VTE burden are needed. The risks for VTE do seem to associate also with the primary malignancy site and histologic subsite. Some of the highest rates are found in patients with primary brain tumors, pancreatic ductal adenocarcinomas, gastric adenocarcinomas, and lung cancers. Patients with hematologic malignancies, particularly lymphoma, are also at increased risk. Low molecular weight heparin, when compared with warfarin, has been shown to reduce the risk of recurrent VTE in patients with cancer-associated thrombosis, and has been widely accepted as a standard of care for over the past 18 years. The seminal CLOT trial was one of the studies that was key in demonstrating the effectiveness of low molecular weight heparin as a standard of care over warfarin. The uses of warfarin in patients with cancer that may have impacted on the findings of these trials comparing it to low molecular weight heparin included the fact that warfarin interacts with many of the chemotherapeutic agents. Nausea and vomiting that our patients may experience when they're undergoing chemotherapy or just related to their tumor itself may be a barrier to taking an oral medication, and patients may have an inconsistent intake of vitamin K during their therapy for their cancer. A small percentage of patients with cancer were included in the large clinical trials that evaluated the DOACs for VTE management. As shown on this slide, however, this number of cancer patients in these trials was quite small. The limitation in comparing these trials to the standard therapy of low molecular weight heparin is that these trials compared DOACs to warfarin and not to low molecular weight heparin. Since these studies came out, there have been a handful of trials now specifically evaluating DOACs in the management of patients with cancer, and here's a listing of these studies with the Caravaggio study that was most recently published in New England Journal of Medicine. It is important, though, to remember with DOACs that they do have drug-drug interactions with chemotherapeutic and anti-angiogenic factors that may alter the potential impact of both sets of drugs. Again, as we pointed out earlier, the P-glycoprotein transport system and the cytochrome P450 system are systems that are actually inhibited by tyrosine kinase inhibitors as well as hormonal therapy. It may be induced by chemotherapeutic agents doxorubicin and vinblastine, along with dexamethasone. So it's important to keep in mind which therapeutic agents they're on and which DOAC you're going to prescribe, because you may alter the efficacy of their chemotherapy or their anticoagulation. Of note, these issues are not seen with low molecular weight heparin. The International Society on Thrombosis and Hemostasis Scientific and Standardization Committee did put forth a scientific guidance statement in 2018, which recommended individualizing your treatment regimen after shared decision-making with your patients. They did recommend the use of DOACs for cancer patients with acute VTE who have a low risk of bleeding and no drug-drug interaction with their current therapy, while low molecular weight heparins will remain an acceptable alternative. They did, however, point out, though, that there are certain cancer scenarios in which low molecular weight heparins would be preferred over the DOACs. And it's mainly because in all of the DOAC trials compared to low molecular weight heparins, in these clinical scenarios, the DOACs had higher rates of bleeding compared to low molecular weight heparins, and those included patients with luminal GI malignancies, cancers that were at risk of bleeding from the GU tract, bladder, or even nephrostomy tubes, and patients who had active underlying GI mucosal abnormalities such as esophagitis, gastritis, ulcers, or colitis. Now let's switch gears and talk about renal disease. VTE in patients with renal disease, ranging from chronic kidney disease to end-stage renal disease, is common and associated with a high mortality and complication rate. In the large Italian REDI registry, patients with moderate and severe renal impairment had a higher incidence of fatal PE compared to patients with normal renal function. In clinical practice, in addition, impaired renal function can pose certain challenges when trying to make the diagnosis of a VTE, as well as trying to come up with treatments for both prevention and therapy for acute disease. For decades, warfarin has been the anticoagulant of choice for patients with renal disease requiring systemic anticoagulation. However, patients with renal disease on vitamin K antagonists spend less time within therapeutic range and are actually found to have more time in supertherapeutic level range and have increased risks of bleeding. Warfarin is also associated with a side effect that's very rare called calcific uremic arteriopathy, which is previously referred to as calciphylaxis. When it does occur in patients with end-stage renal disease, it does have a short-term mortality rate as high as 50%, so nephrologists are trying to find ways to find drugs that don't impart this risk of morbidity and mortality to their patient population. So DOACs have been shown to have similar efficacy and bleeding outcomes as the vitamin K antagonists in renal disease in patients with creatinine clearances between the ranges of 30 and 60 mils per minute. Patients with severe renal impairment or on hemodialysis were not included in any of the trials evaluating DOACs in the VTE population. So let's look at the individual agents briefly. Dabigatran does have the highest renal clearance of all the DOACs. Its levels increase in patients with kidney disease, and it goes up exponentially with the severity of their renal disease. It can, however, be removed with dialysis if you do have drug on board and need to get it removed. Clinical efficacy and safety did not include patients with creatinine clearances less than 30 mils per minute or on dialysis, so it is not recommended in this patient population. Apixaban has a lower renal clearance compared to Rivaroxaban and Apixaban, and in the meta-analysis of 9 trials looking at the safety of DOACs compared to vitamin K antagonists in patients with renal failure with a creatinine less than 50 mils per minute, Apixaban was found to have the lowest rate of major bleeding compared to all the other DOACs. Based on this information, the FDA has put forth dosing recommendations for the use of Apixaban in patients with creatinine clearances less than 15 mils per minute or on dialysis. They did use the pharmacokinetic trials that did demonstrate that after 8 days of exposure to 5 milligrams BID dosing of Apixaban, patients still had higher levels of the drug in their system, but it was still within normal range and noted the lower bleeding rates. Based on this, in end-stage renal disease on dialysis, patients can be given Apixaban at a dose of 5 milligrams twice a day. However, in patients who have creatinines greater than 1.5 milligrams per deciliter, who have moderate renal impairment, or are older than 80 or weigh less than 60 kilograms, they do recommend a dose reduction to 2.5 milligrams twice a day. Rivaroxaban, again, clinical efficacy and safety trials did not include a population with a creatinine clearance less than 30 milliliters per minute or on dialysis. The drug has been shown to accumulate in patients who have renal impairment, so the FDA has made its recommendations for its use and states that for patients with a creatinine clearance between 15 and 50 mils per minute, you can reduce the dose of Rivaroxaban to 15 milligrams daily. However, if your patient has a creatinine clearance less than 30 in the setting of an acute VTE, or they're on dialysis, Rivaroxaban should not be used. Apixaban also increases in concentration as creatinine clearance falls. It too is not studied in this patient population, so the FDA does recommend, again, a reduced dosing if you use Apixaban for creatinine clearance between 15 and 50 mils per minute to 30 milligrams daily, and does not recommend its use when the creatinine clearance is lower or the patient is on dialysis. So in summary, warfarin today remains the most widely prescribed oral anticoagulant in renal disease. However, on the basis of the studies of general population comparing DOACs with warfarin, they do have reduced risks of stroke and systemic embolism with less bleeding side effects. As a result, there's been a lot of patients being put on these drugs off-label use, and now the FDA has included dosing recommendations, including that for Apixaban, which seems to be the favored drug by many nephrologists and internists these days. Let's switch gears to pregnancy. Women who are pregnant or in the postpartum period have a 4 to 5-fold increased risk of VTE compared to non-pregnant women. 80% of their events are venous, with about 75% of them being a DVT and about 25% being a PE. The risk appears to be highest in the immediate postpartum period and slowly decreases back to pre-pregnancy levels between 8 and 12 weeks postpartum. It is a leading cause of morbidity and mortality in women in the United States, accounting for up to 9.3% of all maternal deaths. For women who have a pregnancy-associated DVT, they're at substantial risk of developing post-thrombotic syndrome, which is associated with reduced quality of life. The diagnosis, prevention, treatment of pregnancy-associated VTE is particularly difficult because one needs to consider both the fetus as well as the maternal well-being. Pregnancy is considered a prothrombotic state, and that's what leads to this higher rate of VTE. Women appear to be hypercoagulable with altered coagulation factors. They have increased venous stasis and decreased venous outflow. They have compression of their IVC and pelvic veins by their enlarging uterus, the DVTs being seen most commonly in the left lower extremity, and some of them have decreased mobility. As far as the anticoagulants go, heparin compounds are considered safe in pregnancy, as neither one of them, both unfractionated heparin nor low molecular weight heparin, cross the placenta. There are some unique considerations in pregnancy, though, with regards to the dosing of these agents, in that the physiology of the pregnant female may alter their drug dynamics. Because women who are pregnant have increased blood volume, they can have increased GFR with increasing drug clearance, and they have increased binding proteins as well, which impacts on heparin. Warfarin and other vitamin K antagonists have been associated with potentially harmful effects, especially if given during the first trimester. Warfarin embryopathy happens if the pregnant woman is exposed to this drug during weeks 6 to 12 of gestation, and it's characterized by nasal cartilage hypoplasia, pregnancy loss, fetal bleeding, and neurodevelopmental deficits. It is rarely prescribed in pregnancy, but it's still considered for women with mechanical heart valves because of the high risk of thrombosis even with heparin. Of note, it does not accumulate in breast milk and does not induce an anticoagulant effect in the infant because it does not cross into the placenta. The oral direct thrombin inhibitors and anti-10A inhibitors, or DOACs, are of low molecular weight and do cross the placenta. Their effects on reproductive events in humans are not known. To date, it's recommended that they should be avoided in pregnancy and lactation because there's insufficient data to evaluate safety for the woman, fetus, and breastfeeding neonate. Ex vivo studies do demonstrate that human placentas demonstrate the transfer of DOACs across the placenta, which raises concern for an indirect effect on fetal blood coagulation. And maternal ingestion does demonstrate detectable levels in human milk. In 2018, the American Society of Hematology put forth a set of guidelines on VTE management in pregnancy and did state that pregnant women should receive anticoagulant therapy compared to no anticoagulant therapy, and that low molecular weight heparin is recommended over unfractionated heparin. The American College of Obstetrics and Gynecology put out a practice bulletin that same year and basically said the same thing. The preferred anticoagulants in pregnancy are the heparin compounds. Because of the greater reliability, low molecular weight heparin is recommended over unfractionated heparin for the treatment of VTE within and outside of pregnancy. Warfarin, low molecular weight heparin, and unfractionated heparin are the anticoagulants compatible with breastfeeding. Now we'll move on to obesity. The World Health Organization defines obesity based on their BMI, with a BMI greater than 40 being the definition for morbid or extremely obese. At this time, it's estimated that approximately 7.7% of our adult population meets this definition. Taking both atrial fibrillation and VTE together, there are more than 500,000 extremely obese individuals in the U.S. for whom a decision may be needed regarding whether to use a DOAC or warfarin for their form of anticoagulation. Obesity has emerged as a global health issue that is associated with a wide spectrum of disorders, including VTE. The likelihood of having a first spontaneous event among patients who are obese was more than twice that of individuals of normal BMI. The effects of obesity on VTE risks not only depends on the total body fat, but its distribution and interplay with other VTE risk factors, including thrombophilias, hospitalizations, and oral contraceptive use. Per the FDA-approved prescribing information, none of the 4 DOACs approved for therapeutic dosing in atrial fibrillation and VTE need to be dose adjusted for high body weight or BMI. Therefore, they can be used at standard doses even in patients with extreme body weight. The product labeling of the approved DOACs also reflects that no dose adjustment for high weight or BMI in obese range is recommended. The ISTH SSC guidance statement, forth in 2016, does suggest that DOACs should not be used in patients with a BMI greater than 40 or a weight greater than 120 kilograms. This is based on limited clinical data along with pharmacokinetic and pharmacodynamic data suggesting decreased drug exposure, reduced peak concentrations, and shorter half-lives occurring in patients with increased weight, raising concerns for underdosing in this population. If a DOAC were to be used in this population, they do recommend that you have specific drug levels drawn and followed in order to make sure they're in therapeutic range. Many laboratories do not carry the DOAC-specific anticoagulation levels. So if you have that available to you, you can use a DOAC. However, if your patient is not falling in with therapeutic range on standard dosing, they recommend switching your patient over to vitamin K antagonists and not to increase the dose of the drug. Some additional data has been published since that publication came out in 2016, but it's very limited. Patients in the extreme obesity range do not come out in large numbers in these trials. So at this time, there's no more information to advise us on this issue. And most authorities to date seem to follow the ISTH guidelines of avoiding DOACs in patients with a BMI greater than 40 or a weight greater than 120 kilos. In conclusion, DOACs have revolutionized anticoagulation management and are becoming the cornerstone treatment for both stroke prevention and atrial fibrillation and VTE treatment and prophylaxis with an expanding list of indications. As frontline clinicians, one must assess the following in determining your initial agent of choice as well as its dose. You need to weigh the risks of VTE recurrence versus the risk of bleeding in your patient. You need to understand the drug-specific adverse events as well as potential drug-drug interactions. You need to anticipate dynamic changes in their renal function. One has to consider individual costs, coverage, and availability, the drug dosing, as well as the dosing administration, as well as lastly, your patient's preference. I'd like to conclude now and take any questions you may have on these topics.